unstable with inflammatory cells coming to that site. It makes it a firm thing. Then over time, you find a little piece of it with dislodge, can go to the brain, can grow to the heart. That's how you end up with a coronary artery disease, or you end up with a stroke, as the case may be. So today's case, we'll be looking at when that plaque migrates and gets to the coronary vessel and gets to the heart. So today, I'll be talking about angina and myocardial infarction. We will define them. We look at the differences between the two, the distinct pathogenesis and treatment of ischemic heart disease, the classes of agents that are useful in the management of coronary artery disease. We will give examples, mechanisms of action, and the adverse effects. So angina pectoris is commonly known as angina, and that's when you have individuals have chest pain because of ischemia of the heart muscle. Where does the ischemia come from? The clot, or the piece of the plaque that dislodges from that mass, goes to the heart. When it's blocking the vessel, there's going to be ischemia of the downstream tissues. So that ischemia is what causes the pain. Some of you may have experienced temporary ischemia, like the funny bone. When you hit your elbow against something, that feeling that you have, that's what the heart feels at that time. Or sometimes when you have to shake your leg because there's no blood flow to the legs, that's ischemia. And when the heart experiences that, that is what you call angina. And it's usually due to obstruction or spasm of the coronary artery. And there's this concept of oxygen supply and oxygen demand. See, oxygen supply to the heart comes from the vessels. So if blood is flowing well, oxygen nutrients are flowing well. That's good oxygen supply. Then, if the heart is using just as much of oxygen that is received, the heart is fine. But if the heart is taking too much of oxygen than is being supplied, then you say the oxygen supply is less than the demand, or the demand is more than the supply. So it's either the supply is inadequate or the demand is too much. So angina will result when the oxygen supply is less than what is being demanded. Myocardial infarction, this is the one you call the heart attack. This is what happens when there's a prolonged disruption of flow to the coronary vessel. See, if the plaque reaches the coronary vessel and there's just a period of a few minutes, and the plaque washes away in the blood, or it gets arrested, then you have that temporary pain. We call it angina. But if the blood flow is restricted over a much longer period, then of course you now find that there is going to be death of myocardial tissue, and that is the one we refer to as myocardial infarction. So angina is temporary, myocardial infarction is more permanent. So when you have the reduced oxygen supply, it can cause ischemia. Ischemia, at the stage of ischemia, is reversible. But once it progresses to myocardial infarction, this is not reversible. So that's the meaning of forward arrow. Once it goes to myocardial infarction, it's a one-way track. But when it's still in the ischemia or the angina state, it could still be reversible. So with respect to the pathophysiology of ischemic heart disease, this is the nice, healthy blood vessel. This is the one in which plaque has built up. You could see the fatty streak here. And you could notice that the fatty streak is narrowing the lumen of the vessel. The amount of blood that could be supplied to the tissues here is much greater than the amount that can be supplied here, because there's a reduction in blood flow. And to worsen it, you may end up with a blood clot right inside here, and that's what really prolongs the ischemia. There are two categories of ischemic heart disease. You have the acute one that you refer to acute coronary syndrome, and we have the chronic one, which is called chronic artery disease. So when it is acute, you just call it a syndrome. And when it is chronic, which is over a long time, you call it coronary artery disease. So what are the categories of those under the subcategories under acute coronary syndrome? You have unstable angina, you have stemming. Stemming means ST segment elevation myocardial infarction. You will remember from your and I thought cardiovascular system, we treated the EKG. There is the ST segment, there is the P wave, there is the QRST, and that's right. So the ST segment there, when it's elevated, we call it ST segment elevation myocardial infarction. If there's no ST segment elevation, we call it N-stemming, that is non-ST segment elevation myocardial infarction. So the acute one here is unstable, but the chronic one, it is stable, and that's why you call it chronic one. Now, to talk more about the pathophysiology, when you have a normal blood vessel, this is the cross-section of it. The lumen is clean, it's clear, there's no deposit of anything on the endothelium, this is normal. The lumen is patent, the endothelial function is great, there's no platelet aggregation. When you get to the one that is stable, this is the chronic artery disease. You see the plaque that is formed in the smooth muscle underneath the endothelium. It pushes against the endothelium, and the lumen is narrow because of the plaque. And sometimes you end up with inappropriate vasoconstriction. You just find the blood vessels with constricting and contracting. The third one is the unstable one. This is when the plaque has a rupture. If you remember what I told you under atherosclerosis, when the plaque is ruptured, that is when you have a number of problems. And the ruptured plaque can actually form a thrombus, and the thrombus will have platelets that aggregate or adhere to the surface of that because it's because of the injury that is caused to the endothelium. Then there's another type which you call the variant angina. In this case, there's no plaque, there's nothing, but the vessels just experience vasospasm from time to time. There is intense vasospasm in that situation, so you refer to that as variant angina. Now, I've given you this before, that ischemic heart disease can be chronic or can be acute. If it's acute, it can be either unstable angina or end-stemming or stemming. And to just refresh your memory on the EKG, this is your typical P wave, this is the QRS wave, this is the T wave. And you have what they call the ST segment here, ST segment. So when we're looking for myocardial infarction, or when our parents have been told to go do annual checkup and looking at the EKG pattern, what the physician is looking at is the different waves, the pattern of the waves, and the times that it takes for each of these waves to occur. That would give an indication of an ongoing heart condition. In this case, you could see ST segment depression. See, ST is here. This segment is depressed. In this case, you have the T wave inverted. So you call this one T wave inversion. And in this case, you have the ST segment being elevated. So if you talk of end stemming or stemming, this is the region we're talking about, that there's elevation of the ST segment. Now, when it comes to management, the management will depend on the category of ischemic heart disease. So if it is acute or it is chronic. because each of them has a distinct pathogenesis, therefore, you've got to treat it differently. You have to adopt certain strategies that is specific for each. So when you have acute coronary syndrome, in this case, what you want to do as a goal is to restore and maintain the patency of the coronary vessel, just as early and as quickly as possible, to restore and maintain patency, because if it's not done on time, it can proceed to myocardial infarction. If you have chronic artery disease, because this is, if you have coronary artery disease, this is chronic. In this case, it has gone beyond rushing to maintain the patency of the blood vessel, because this has been there for some time. So what we now want to do is to maintain the balance between oxygen supply and demand. So you want to improve coronary blood flow in order to increase oxygen supply, and you want to reduce the working of the heart so that the heart does not demand so much oxygen. And as we go forward, I want you to know that when the heart is contracted, the heart is taking a lot of oxygen for that action to occur. That's what we call oxygen demand, because it has to have oxygen in order to do its work. So when you have to manage coronary artery disease, you want to make sure that the oxygen consumption by the heart is low, and that means the oxygen demand is low. So let's look at clinical management and what we will do. So if you want to treat angina, we want to know what is causing the cause of it. And I've been talking to you about plaque buildup, plaque in the coronary arteries. When the plaque builds up in the coronary arteries, what happens? Coronary blood flow will reduce. So one of the goals of treatment, or the strategies for treatment, is to increase coronary blood flow. There will always be an increase in platelet activity, and there will be an increase in sympathetic activity. These three would be the resultant effects of a plaque on the heart. And so we will talk of agents that will do just, that will be targeting these three things. Last week, we talked a lot about anticoagulants. That's when we're talking about venous thrombi. Somebody had asked me, was that you, Brandy, asking me about some agents, and I said those are antiplatelet agents. So, we treated anti-clotting factors last week. This week, we were doing a lot of the antiplatelet agents, and she was asking about two of those agents. And I said, I'm going to give you a long list of them today. So help you guys. So be careful what you wish for, because you will get it. So when it comes to chronic coronary artery disease, you've got to focus on reducing oxygen demand. And so anything that can increase the heart rate, because the heart rate, the faster the heart beats, the greater the demand. You've got to focus on contractility of the heart, because the more the heart contracts, the more the oxygen that it consumes. And then is ventricular wall stress. If the stress on the ventricular walls is high, you need to reduce it. So the fourth group of agents we use would be the beta antagonists. We've treated beta antagonists very well under hypertension. So there's not any information I need to give you here, but just to revise that it reduces heart rate, therefore it's helping oxygen demand. So it causes a reduction in contractility of the heart. So that is here. So that's positive, negative inotropism and negative chronotropism. And on top of it also, it can reduce the conduction of the AV node, so that it slows down the transfer of impulses from the AV node to the rest of the ventricles. By doing so, it allows the myocardial tissues to receive a little bit more oxygen That's why you call it increase in myocardial perfusion. That's what I'll tell you mainly about beta antagonists. This one, we're just trying to explain to you more what happens that when you have chronic angina, these agents will reduce the peak heart rate, especially during exercise. When people go for exercise tolerance test, that's when you want to test the function of the heart. You put them on a treadmill, you run, you take the heart rate before and after. There's a certain height, there's a peak increase in the heart rate that people reach for which you say stop. That's why you call it exercise tolerance test. When the heart rate goes beyond a particular point that the individual starts palpitating, then you say stop. So what happens when you give beta antagonists is that it will reduce the peak heart rate during that exercise tolerance test. And of course, it will delay the time to the onset of angina. It is often used in combination with organic nitrates or the CCBs, especially the DHBs, and I'll mention that in a little while. What are the contraindications to beta? Yes, ma'am.
Doesn't exercise increase your heart rate?
Yes, it does.
So do we advise them to continue to work out if they're
No, you have to continue to work out.
Yeah, no, I know that, but like, isn't it kind of like redundant? Isn't it going against each other? Like to tell them, like, because you're giving them medication that's going to lower their heart rate.
The exercise you do normally, as somebody that has heart issue, that's fine. But when you want to find out how bad the heart function is, put them on a treadmill or that's what we call exercise tolerance. How far can individuals go? For sometimes it's something you can do at home. Tell dad or uncle to just go up the staircase and come down until you say, no, I can't continue. That's what you mean by exercise tolerance. So if you took the heart rate at that point and it goes from, let's say 72 to something like 140, okay, what we're saying is that if you give a beta antagonist, it will reduce that peak heart rate. So what happens is this individual will be able to do more when it's under the influence of the beta antagonist. Good. Okay. So what are the contraindications? The beta antagonists are well tolerated except for what you know in terms of lipid profile and hyperglycemia and all that. Please make sure you do not use or at least be careful when you have to use beta antagonists with the non-DHP CCBs, and you know why. The non-DHP CCBs are the ones that act primarily on the heart, right?
Yeah, cardiac tissue.
Exactly. So that's a double whammy. So you've got to be careful when you do that. Then when individuals have decompensated heart failure, and I think when we do 505 or in the lab, you come across when we do heart failure. Heart failure can be compensated or can be decompensated. And I'll treat heart failure later too. When there's heart failure that's compensated, that means the individual is living nicely with it. The decompensated one is the one that's not that great. So you've got to be careful when you give it to patients with decompensated heart failure, because then it depresses the heart even more. Then of course you want to be careful when you give it to patients that have asthma and chronic airway obstruction. And this applies mainly to the non-specific beta antagonists, because when you're blocking the beta 1 and you're blocking the beta 2, then you are leaving alpha receptors untouched, and you know that you need, for example, for the in asthma patients, you need them to have their beta 2 receptors intact. And chronic airway obstruction, you need their beta 2 receptors active. So do be careful when you're giving it to patients that have asthma and chronic airway obstruction. Then in patients with peripheral vascular disease, and I will treat that tomorrow, peripheral artery disease. This is because you are antagonizing beta 2 mediated vasodilation. You need beta 2 because it causes vasodilation. So when you are giving a beta antagonist with B1, beta 1 receptor, which works primarily on the heart, don't forget that there's a B2 mediated vasodilation. So you got to go for selective beta 1 receptor antagonist that will allow beta 2 to do its work because they need the beta 2 vasodilation. Avoid giving the avoid giving the non-specific ones like propranolol. This is what this means. Okay. Now the side effects: fatigue, lethargy, insomnia, impotence, and all that, as we covered under beta antagonists when we did hypertension. Now the next one, the next group will be the CCBs. And you know well about the CCBs now. What are their own effects? They reduce oxygen demand too. Because you know the CCBs reduce systemic vascular resistance and they reduce contractility. But they may also increase oxygen supply because they can cause vasodilation. Of course, you know the non-DHPs, selective effects of the heart, the DHPs for peripheral vasculature. Most of these ones they have the potential to elicit negative inotropism. And because of that, that's why certain of those CCBs have to be avoided in decompensated heart failure. But you have the newer generation ones that patients with heart failure can do well on. There are two of those ones, amlodipine and felodipine. These ones are well tolerated by patients that are classified as heart failure patients. Now, how are the CCBs different from the beta blockers? They are effective in the treatment of vasospastic angina. Vasospastic angina is that one that I told you just has excessive vasospasm. There is no plaque, nothing. The vessels are just prone to excessive vasospasm. So in this case, the CCBs are better than the beta antagonists because it goes straight to deal with that vasospastic angina because of their vasodilator effect. The next category of agents to use are the nitrates. And the nitrates, the prototype is nitroglycerin. The others are isosorbide mononitrate, ISMN, or isosorbide dinitrate, ISDN, or erythritol tetranitrate. I want to believe that Dr. Chelia will tell you more about the chemistry. But what's the difference between these nitrates? They differ in volatility. For example, nitroglycerin has moderate volatility. Amine nitrate is very volatile, whereas the ISDN and ISMN are solids at room temperature. So that's one difference. The second difference is in terms of pharmacokinetics. Nitroglycerin is lipid soluble and is readily absorbed from the sublingual mucosa. It has a rapid onset of action of about 2 to 5 minutes, and it has a peak effect in 10 minutes. Total duration of action is 25 minutes. And while I'm on this, let me just mention something that I believe I've mentioned in the past, but it's worth repeating. Sometimes it's difficult to distinguish between somebody that has angina and somebody that has myocardial infarction because everyone complains of pain. But there's something you can use to do a quick diagnosis. Say, if you give the person you suspect has myocardial infarction, now if you give someone that you suspect has angina, if you give it nitroglycerin, because of the rapid onset of action, the person just comes back alive quickly, within 2 to 5 minutes. But if you give the nitroglycerin to the patient you're suspecting has angina, still complaining 30 minutes after, then you know that that person has myocardial infarction. That make my point clear? Very clear. So nitroglycerin can be used both as a treatment as well as a diagnostic test to separate angina from myocardial infarction. If you give it and it's easy, put it under the tongue. It gets readily absorbed from there. 2 to 5 minutes, the pain just disappears. If it's angina, if the pain does not disappear, you give it another 10 minutes, the pain still does not disappear. By the time it reaches 20 minutes, you know that the heart tissue has gone into ischemia, prolonged ischemia. That's myocardial infarction now. So, okay, unlike nitroglycerin, ISDN, and erythritol tetranitrate, no, just like that, just like NTG, these ones are also administered sublingually. However, they have a slower onset of action and they have a slightly longer duration of action. So, ISDN given by the sublingual route, the onset of action will be like 5 minutes, or the duration of action is about 1 hour. But the question is, how easy is it to distinguish between the two? Between the ones with short onset of action, rapid onset of action, and short duration of action, just find out that NTG is 3 letters. ISDN and erythritol tetranitrate are too long. I think that's why they have a slower onset of action. They have more letters than NTG. Okay. That makes it easier for you to not bother yourself trying to memorize what it is. ISDN and erythritol, the I is too long anyway, so that's the one that has the longer duration of action. That's what I mean. Okay, let's now go into the mechanism of action of the nitrates generally now. What they do is they activate soluble guanylyl cyclase. Say guanylyl cyclase is just like adenylyl cyclase. Adenylyl cyclase is for ADP and it's for ATP, but guanylyl cyclase would be for GTP. So what adenylyl cyclase is doing to ATP is what guanylyl cyclase is doing to GTP. So for adenylyl cyclase, it generates cyclic AMP, correct? In this case, it will generate cyclic GMP. And when the cyclic GMP is generated as it is increased, it automatically reduces intracellular calcium. Don't forget this relationship that cyclic GMP is related to intracellular calcium. The higher the cyclic GMP, the lower the intracellular calcium. And when you lower the intracellular calcium, they almost start to behave like a calcium channel blocker because there's not enough calcium for the tissue to use. So there'll be a reduction in contraction or even relaxation of cardiac and vascular smooth muscle, which will now lead to a reduction in systemic vascular resistance, will reduce cardiac contractility, both in the blood vessel and the heart. And the nitrates have a particular action on inhibiting platelet aggregation. So it's one of the agents that are anti-platelet agents. They inhibit platelet aggregation. What are their other effects? They dilate the peripheral capacitance veins. So they are venodilators. There are certain agents that are arterial vasodilators, and there's primarily venodilators. So by doing that, because they act primarily on the veins, they will reduce the preload. Because they reduce the preload, they will reduce the amount of oxygen the amount of blood that's been dumped in the heart. Therefore, the demand for oxygen will be less by the heart because the heart does not have to deal with too much of load. That's how the demand for oxygen is less by the heart under that condition. They can also increase coronary blood flow. especially in patients with vasospastic angina. So like the CCBs that act on vasospastic angina, the nitrates also act on vasospastic angina patients. Of course, we mentioned about the effects on platelets, and in terms of preparations, they come in form of tablets, in form of sprays, in form of intravenous injections, and also in form of a patch. The major issues with the nitrates is that when you use them over a long time, tolerance develops. Tolerance develops tachyphylaxis. So you have to increase the dose from time to time. That's a major issue with them. And of course, like most vasodilators, they cause headache. They cause headache as a major issue. Right. So let me see if you've been following me. Can you answer me true or false? All forms of acute coronary syndrome are characterized by elevation of ST segment. False. That is false. Number 2, beta antagonists are often used in combination with non-DHP CCBs.
False.
Okay. CCBs increase oxygen supply and reduce oxygen demand.
False.
While beta,
True.
that's actually true. While beta antagonists only reduce oxygen demand. Yeah.
Yeah. And they reduce it as well. So the beta antagonists reduce it.
Because it's reducing the blood pressure?
Thank you, dude. That's very good.
Out of breathing?
That statement is correct. The CCBs will increase oxygen supply and reduce oxygen demand. What the beta antagonists do primarily is to reduce oxygen demand. Reduce oxygen demand by reducing heart rate, by reducing contractility. Okay, now let's go to Brandy's favorite subject now. She said the antiplatelet agents. Now, when there is injury to the blood vessel or any site at all, once there's that surface contact, as we're having the clotting going on in one place, you have the platelets being attracted to that site. First thing the platelets will do is they will adhere together. We call that platelet adhesion. Then they get activated. Then they start aggregating. And the easiest way that I've always taught platelet function is this. If there's going to be a major demonstration downtown, you know, and let's say TSU students want to march against their professors, they're not teaching them well, or the tuition fees are too high, or there's too much insecurity on campus, all those long list of things that students complain about, the hostels are lousy and terrible and all that. You know, you start talking to each other first. So that's platelets talk to each other too. So one person talks to one person, the other one does. That's what we call platelet adhesion. Students are adhered to each other. Then that's it goes on to the stage of activation. So yes, you got to do it. Yeah. Let's go downtown. Let's carry placard. Yeah. Then you got more people. That's activation. Then some of you that live in highway, I-10 or something like B45 and everything. Then you now come back. You come together to meet in one spot. In front of City Hall. That's now aggregation. So you go from adhesion to activation to aggregation. And so this is what is happening here. So when platelets now aggregate, they release the content of their granules. And those granules are the ones that now activate the prostaglandin and thromboxane A2 system. Thromboxane comes from the word thrombosis. So what are the targets for platelet inhibition? Then how do you antagonize platelets? You can antagonize any of these steps. particularly if you antagonize this system, then you are going to end up with an antiplatelet agent. This is not all though, there are other targets. If you remember this slide from last week, where I talked about the target of therapy, okay, talked about platelet adhesion, activation, and aggregation. What does it involve? It involves a von Willebrand factor. It involves a glycoprotein 1 receptor. It involves the release of platelet products. These products are contained in granules inside platelets. And these are ADP, thromboxane A2, and there's also a glycoprotein 2B3A receptor. All of these are the ones you use as targets of therapy when you're treating, when you have antiplatelet activity to achieve. And of course, don't forget our revision of arterial and venous thrombi. One contains mainly of platelets, and that's why we'll be giving a lot of, that's why we'll be treating antiplatelets a lot of today. And then what brings it about? Rupture of atherosclerotic plaque. Just using this to reinforce what we did last week. Now, when it comes to mechanism of inhibition of platelets, I mentioned to you that there are prostaglandins and thromboxane A2. There is arachidonic acid. And arachidonic acid can be metabolized by cyclooxygenase. You know that one? By COX. So when you talk of COX, you are in the process of yes, the arachidonic acid is present in platelets, it's present in the endothelium. Let's look at the one in the platelet. The arachidonic acid gets converted to thromboxane A2. And the one in the endothelium gets converted to prostacyclin. Okay? Prostacyclin stimulates adenylate cyclase. Thromboxane A2 inhibits adenylate cyclase. So when thromboxane inhibits adenylate cyclase, it reduces the formation of cyclic AMP. And it is cyclic AMP, so by doing so, it does affect the addition of platelets. When prostacyclin is formed, there is more of cyclic AMP that is formed, and this cyclic AMP is the one that inhibits the adhesion of platelets and the release of its granules. So the preferential thing is for arachidonic acid to be converted to prostacyclin, because prostacyclin will increase cyclic AMP and will now inhibit platelet aggregation. The other one is you will want to block thromboxane A2 so that thromboxane A2 does not have much effect on adenylate cyclase, and it can get a copious amount of cyclic AMP2. While I'm on this, let me mention to you, anytime you hear about low dose aspirin for the for the treatment of heart condition or thrombus formation and all that, this is what happens. Low dose, not the full dose, the 75 milligram tablet per day. The low dose aspirin has a preferential effect on the cyclooxygenase that's in the platelet. So, when it blocks the cyclooxygenase in the platelet, this does not even form. So, this aggregate does not arise, leaving the whole of the arachidonic acid to come to prostacyclin. Is that clear to you now? When you use low dose aspirin, it does not block both the COX in the endothelium and the one in the platelet. Preferentially, it blocks the one in the platelet. So when it blocks the one in the platelet, arachidonic acid that is present that would have gone this way has not gone that way. So thromboxane A2 is not formed. Because somebody asked you, so why am I using low dose aspirin? Why not the full dose aspirin? No, the full dose aspirin will block both of them. And you don't want to block both of them. You want to preferentially block the one that is metabolized in the platelets. Okay? And sometimes when you want to show the patients that you understand the pharmacology of it, then instead of just saying it that you preferentially block the one in one tissue versus the other, you can then go into full thing and say, no, platelet and arachidonic acid gets converted to cyclic endoperoxide, we then does adenylyl cyclase, we then does this. The patient will just, okay, so in effect, what are you saying? So what I'm saying is low dose aspirin preferentially blocks the cyclooxygenase in platelets so that less thromboxane A2 is formed and more of prostacyclin. And prostacyclin is the anti-platelet agent, whereas thromboxane is it promotes platelet aggregation. Okay, now this is looking at the platelet now and some of the signaling mechanisms. If you have the platelet here, and it has what we call an adenosine or a purinergic receptor, purine. We call it P2Y12 receptor on the surface of the platelet. This is the one that ADP will combine with in order to cause aggregation. So the P2Y12, when stimulated, can also stimulate what we call the PI3K. And don't worry too much about PI3K, but worry more about the GP2B3A. The GP2B3A, that's the glycoprotein 2B3A complex, is also located in the platelet. So there's a good link between the P2Y12 receptor and the GP2B3A. Stimulate this, it invariably affects the expression of this receptor. And it is this one that actually carries out the platelet activation step. So when ADP is released from the platelet and goes out of the platelet, the same ADP goes to stimulate this receptor on the surface and therefore causes this to occur. If you want to antagonize platelet activity, therefore, you can use antagonism of this receptor, because if you antagonize this receptor, you ain't going to get the GP2B3A receptor to do its work, and therefore there's not going to be platelet activation. What are these P2Y12 antagonists? You have clopidogrel, you have prasugrel, you have ticagrelor, you have cangrelor, you have elenogrel, a number of the grel, and the grelors. Okay, this other slide shows you in a little bit more details. Don't worry about the details, I'll break it down. Don't forget, we talked about activation and we talked about aggregation. For activation, this is the platelet, and this is the thromboxane A2 and its receptor. The thromboxane A2 is contained in the granules in the platelet, just like ADP. So when platelets are activated, both of these are released into the blood. They now go around to combine with their receptor on the surface of the platelet. While they are inside there, they are not doing much. They have to be released and out and block this. And when you give a thromboxane inhibitor like aspirin, this is where it is acting. It is acting at the level of the thromboxane A receptor. Now this is ADP. When ADP is released too, the ADP combines with its receptor, P2Y12 receptor. Forget about thrombin. I won't talk about thrombin today because none of these antagonists are available in the market. This is just for research curiosity. These are the same ADP receptor antagonists of the previous slide that I mentioned. Now, after the activation has occurred, I told you there's a link between the P2Y12 and the GP2B3A. It is the GP2B3A that's involved in aggregation directly. The activation step involves this receptor. The aggregation itself involves this receptor. And this receptor is the one that now causes fibrinogen and fibronectin to now cause the platelets to aggregate. And there are inhibitors of this particular molecule. You have absciximab, you have eptifibatide. Those would be the inhibitors of the GP2B3A, as opposed to the ADP receptor antagonists, these ones that I've mentioned before. Now this even gets more interesting or more complicated. But just put your eyes on activation. We're still on the activation step now. And what I want you to pay attention to is at this point. See, the ADP is released from, when it's released from the granule, just like thromboxane A2 will be released, certain things happen. Here, you see the P2Y12 receptor is linking up with the GP2B3A receptor to allow aggregation to occur. When you give antagonists of P2Y12, they invariably affect this process. What are those antagonists? For the P2Y12, ticagrelor, cangrelor, cyclopidine, clopidogrel, prasugrel. That's just one piece of information that's important that I want to emphasize here, is that there are 3 of these are prodrugs: cyclopidine, clopidogrel, and prasugrel are prodrugs. They have to be metabolized before they can combine with P2Y12. Whereas ticagrelor and cangrelor do not need that because they are active metabolites on their own. And I will ask you a question around that. I want to know whether you can make a distinction between the prodrug and the one that acts directly on P2Y12 and securely.
So that blue arrow is supposed to be, that one right there, yes. So that's supposed to be telling us that the P2Y is interacting with the GP2B.
When you activate P2Y12 receptor, it's the one that causes an amplification of the expression of this receptor.
Okay.
And when this receptor is expressed, that is when you get aggregation.
Okay.
Without this, you don't get the aggregation.
Okay.
So when you want to avoid it, when you want to block the aggregation, you can do it right at the level of the P2Y12. That's what it means.
Okay.
Right. So that's the only information that I want to give you here that is relevant. I don't want you to have I don't want you to have more than I'm giving you there. Now, this talks more about mechanism of action too. And in this case, we're just including one more step. And I'm sure you know that when from ATP you go to cyclic AMP, there's adenylate cyclase that leads you there, right? The cyclic AMP can be broken down. What's the enzyme that breaks it down? That breaks down cyclic AMP. Okay. All right. Smart one. Phosphodiesterase. So we're looking at a situation you need cyclic AMP to antagonize platelets. You have 2 options. It's either to stimulate adenylate cyclase to produce more cyclic AMP, or to inhibit the breakdown of that cyclic AMP by phosphodiesterase. Are you following me? Okay? One stimulates cyclic AMP, one breaks the cyclic AMP down. Since you need an increase in cyclic AMP as an antiplatelet mechanism, you either stimulate adenylate cyclase to get the cyclic AMP, right? Or you inhibit phosphodiesterase so you can accumulate cyclic AMP. You with me? Okay. So in that case, if you want to use phosphodiesterase inhibitors, you have two examples that you can use: cilostazol and dipyridamole. Those are phosphodiesterase inhibitors. And what they do is they inhibit the conversion of ATP to, when cyclic AMP is formed, they do not allow the cyclic AMP to break down. So cyclic AMP accumulates. And in this case, you have, these are the examples of the GP2A receptor. This is the platelet here. So the P2Y receptor is here. The P2Y12 receptor is here. And these are the two agents that we mentioned that are P2Y receptor antagonists. And this arrow is leading to the fact that, and that's the question Creone was asking, but the P2Y12 receptor and is linked to the GP2A receptor. When the P2Y12 receptor is activated, it helps the expression of the GP2B3A receptor, and clopidogrel and cyclopidine are acting on the P2Y12 receptor. The abscessimab, eptifibatide, and tirofiban are acting as GP2B3A receptor antagonists. They are blocking this receptor. That is the information that I'm giving on this slide. We've talked about the clopidogrel and cyclopidine, mentioned about the GP2B3A receptor. The only additional one I've given you in this slide are the phosphodiesterase inhibitors in cilostazol and dipyridamole. So if we talk about the antiplatelet agents now, with aspirin, I've told you it's a preferential, irreversible inhibition of platelet cyclooxygenase, so that there's less of thromboxane A2 production and accumulation of prostacyclin. And this effect is seen only with the low dose aspirin, and it's effective at low dose or when you give them at infrequent intervals. And when you block the cyclooxygenase in platelets, it lasts for the lifespan of the platelet, which is about 10 days. And so the effect is usually strong in chronic coronary artery disease. And if you go back to the case study for today, you'll find out that the patient was placed on low dose aspirin. It's because there's a strong effect of low dose aspirin in coronary artery disease. What are the contraindications to aspirin? Of course, you know, typically anytime you suspect bleeding, you do not give aspirin. So in ulcer patients, you try to avoid it. In those that have liver function compromised, could lead to bleeding. And there are those ones that are allergic to aspirin themselves. When you find a patient that's allergic to aspirin, the alternative you give is clopidogrel. Clopidogrel is a P2Y12 receptor antagonist. Give clopidogrel. Okay. Question. In patients allergic to aspirin, ticagrelor is the recommended alternative antiplatelet agent. False. The recommended one is clopidogrel. Thank you. Now, let me talk about the GP2B3A receptor antagonists. And the two examples I have are eptifibatide and abscessimab. These are effective antiplatelet agents. And you know that GP2B3A receptors are on the surface of activated platelets. And that receptor is required to bind to fibrinogen and form a platelet thrombus. Because you do not want that thrombus to form, you got to antagonize that receptor. So the antagonists, when you give them, they will prevent the formation of a platelet block. Let's talk more about the eptifibatide. It's a synthetic peptide and has anticoagulant activity. It can bind selectively and reversibly to the GP2B receptor and then prevent binding of fibrinogen and all that. And as a result of that, it inhibits platelet aggregation and prevents the development of thrombus. So it has two effects. And those two effects, platelet aggregation inhibition and anticoagulation. And we come across some other ones that block both platelets and block coagulation factors. But the first of the example I'm bringing to you is the GP2B3A receptor antagonist. With respect to pharmacokinetics, I won't bore you with the pharmacokinetics, but what are the uses? It's used for the management of unstable angina. And don't forget, unstable angina is one of the subclasses of acute coronary syndrome. It's also useful in patients that are undergoing coronary angioplasty and stenting because they are good in preventing platelet formation. Don't forget, in stenting and coronary angioplasty, you're introducing foreign surface that can affect the endothelium and therefore bring about some injury to the endothelium. So you go for GP2B3A receptor antagonist. Let's talk about ADP receptor antagonist as the last group. This is an antiplatelet agent that belongs to the thienopyridine class. And Dr. Chelia will talk to you more about the thienopyridine class. They're structurally and pharmacologically similar to thiaclopidine. It is an irreversible P2Y12 receptor antagonist which inhibits platelet aggregation and also acts as an anticoagulant. So, just like the GP2B3A receptor antagonist, clopidogrel is also a platelet aggregation inhibitor and an anticoagulant. What are they useful for? To inhibit blood clot and prevent heart attack and stroke. When there's peripheral artery disease, or coronary artery disease, or cerebrovascular disease. It's useful in the treatment of stemming and non-stemming, or even unstable angina. All cases under acute coronary syndrome. And strangely enough, this has a benefit in smokers. Most of the time we say smoking is bad, but if you have a patient that's on clopidogrel, tell him to go and smoke. Because the benefit is primarily in smokers. Strange. Smokers benefit 25% more and 88% in non-smokers. So it's one of the strange drugs I know. I mean, I don't know why, but those who work on the pharmacokinetics of the drug came up with this research. And don't forget, clopidogrel is the one that is recommended as alternative to aspirin. Remember? That's clopidogrel for you. So you can tie the two together easily. The one that's recommended as alternative to aspirin is the same one that has more benefit in smokers than in any other thing. It is a prodrug and it's activated by cytochrome P450 to form a active metabolite which now combines with ADP receptor. In one of the slides that I showed you before, then you see that it is a prodrug. That is fine. What are the common side effects? Headache, nausea, easy bruising, itching, and heartburn. The adverse drug reactions with this, very serious. It can have severe neutropenia. It can have what we call TTP. TTP is thrombotic thrombocytopenic purpura. Hemorrhage is also an adverse drug reaction to them. Don't forget, an agent combines an antiplatelet activity plus anticoagulant activity. That should make sense to you that a number of the problems will be related to hemorrhage, and therefore TTP will be part of it. And of course, cardiovascular edema. And so, quiz for you. Clopidogrel or eptifibatide, either of them has antiplatelet and anticoagulant effects. True or false?
True.
That is true. Eptifibatide is a GP2B3A receptor antagonist. Eptifibatide is a GP2B3A receptor antagonist. Clopidogrel has antiplatelet and anticoagulant effects. Both of them do that. Then clopidogrel is more beneficial in smokers than in non-smokers.
True.
That is true. And that is where I will end the class for today. I will continue tomorrow, but I will, because of the request by some of you, I will do tomorrow online. Is that fine? Yes. Yes. Okay, we'll do it tomorrow online. So I'll meet you tomorrow.